Good evening, everyone. Thank you for joining us today for this webinar on O-RADS Ultrasound, consultant radiologist at Vijaya Diagnostic Center, Hyderabad. And I'll be the moderator for today's session. Today, we'll dive into Ovarian-Adnexal reporting and data system for ultrasound, that is O-RADS US. As we all know, it is important to evaluate ovarian cancers and any adnexal mass to improve the outcomes and treatment and reduce the unnecessary investigations and interventions. O-RADS provides a structural framework to help with this. Our esteemed chief guest and our speaker will guide us through the key principles of O-RADS. I am honored to introduce our chief guest, Dr. Shruthi ma'am. Welcome, ma'am. I'll briefly go through her profile. Dr. Shruthi ma'am has an impressive academic background, starting with her MBBS from Sri Siddhartha Medical College, Karnataka, followed by an MS in Obstetrics and Gynecology from Goa Medical College. She has further specialized with an ICOG fellowship in reproductive medicine and a diploma in cosmetic gynecology from ICCG. Her professional journey is equally commendable, having served as a consultant at a Rural Development Trust Hospital in Kalyana Durga and Medicover Hospitals, Kurnool. Currently, she is a senior consultant at Gemcare Kaminini Hospitals, Kurnool. We warmly welcome you, ma'am. It's an honor to have you in this session. Now, it's my pleasure to invite our subject speaker, Dr. D. Sreenivasulu, sir, a consultant radiologist at Vijaya Diagnostic Center, Hyderabad. And likewise, our speaker has an outstanding academic trajectory, having pursued education at some of the most prestigious institutions, starting with MBBS from JIPMER, Puducherry, followed by MD Radiodiagnosis from PGIMER, Chandigarh. Also, he has 1 year experience of senior residency from the same institute. He has presented various posters, papers in few prestigious conferences as in European Society of Radiology 2019, Chandigarh chapter of IRA 2020. He also won second prize for an oral presentation in annual conference of Chandigarh chapter IRA 2021. Welcome, sir. Welcome to the session.
Thank you, Dr. Vaishnavi.
Ma'am, would you like to speak few words on the topic?
Actually, this is a very interesting topic, especially for the gynecologist, because we have many doubts regarding after seeing the report of ultrasound, whether we should operate or not for this case. Actually, this webinar, I think it will be useful for all gynecologists. We can get an idea which to operate and which we should refer to oncologist.
Yeah. With that, I think, sir, we can start with the presentation.
Okay, thank you. Okay. So we'll be discussing about the O-RADS system, mainly for the ultrasound, and it is a consensus guidelines quoted by American College of Radiology. Okay, so we need to discuss why there is a need for lexicon and risk stratification. So, like as Shruthi ma'am told, like we need accurate characterization of the ovarian-adnexal masses for optimal management of the patient. So, as we all know that early referral to oncologist can have a better ovarian cancer outcome, and conservative approach and minimal surgical procedures are needed in young patients who have like relatively benign lesions, benign adnexal lesions, so that we can reduce the morbidity and maintain hormonal competency rather than undergoing strenuous surgeries. So, as we all know that there is a interpretation of sonographic findings is variable because of inconsistency in the terminology used by many of the sonologists. So to streamline that terminology like O-RADS ultrasound O-RADS system has been advocated by American College of Radiology, so that we can avoid the vague terms, so that it simplifies the interpretation and subsequent management strategies. So with this motto, it was O-RADS was published by American College of Radiology. So to improve the quality and communication between interpreting and referring clinician, limit variability in reporting language, guide patient management based on actionable information in the imaging report. So we have O-RADS for both MRI as well as ultrasound. We'll be concentrating on the ultrasound part of it today. Till now, before the introduction of O-RADS, pattern recognition by an experienced ultrasound examiner has been considered as the most accurate ultrasound method of discriminating between benign and malignant adnexal lesion. If some experienced radiologist tells that it is benign, it was considered as benign. If he tells that it is malignant, it was considered as malignant before. But to avoid all that things, O-RADS has been published. So as we all know that there is varied level of expertise of practitioners who perform and interpret sonograms, and we need to improve risk stratification with standardized and evidence-based algorithms. So the standardized lexicon that includes this lexicon includes pertinent descriptors and definitions of the characteristic ultrasound appearance of normal ovaries as well as ovarian and other adnexal lesions. So these proposed guidelines are a collaborative, multidisciplinary international approach incorporating both European and North American approaches. The guidelines include all risk categories with their attendant management strategies. So in prior systems, attendant management strategies was not included, but this system includes the attendant management strategies as well. So similar to BIRADS, as we all well familiar with, this lexicon also has 6 categories from 0 to 5. So we'll be discussing each of them briefly in subsequent slides. So there are few governing concepts for this O-RADS. This lexicon is a guidance to the management of patients with ovarian or other adnexal lesions, and individual case management may be modified by professional judgment. If we think that the lesion is benign on evaluating with O-RADS, but to our clinical judgment it looks as malignant, then based on individual case it can be modified. So we should not strictly follow the O-RADS as such. So the management system is based on average risk patient with no acute symptoms and no substantial risk factors. So this is not applicable for patients who have prior history of family history of ovarian cancer or BRCA gene running in their families. So those patients are excluded, and even for acute patients with acute symptoms like ovarian torsion and all. So one of the governing concept is categorizing the patient as pre or post-menopausal women. So post-menopausal category is defined as amenorrhea of greater than or equal to 1 year. So if the patient has no periods for a greater than or equal to 1 year, then she falls into the post-menopausal category. So another important element of this lexicon is the size of the lesion. It is an important element in risk assessment. It is obtained by measuring the largest diameter of the lesion regardless of the plane in which the diameter appears. So in any of the orthogonal planes, if the diameter is largest, we consider that as the size of the lesion. And this lexicon is applicable to both ovaries and fallopian tube lesions. If the pelvic lesion is indeterminate, but to our clinical judgment it appears to be arising from ovarian or fallopian tube origin, then O-RADS may be applied. And few special categories are there, like para-ovarian cyst or peritoneal inclusion cyst, which are not from ovaries, but they have been included in the O-RADS class lexicon. So, and this is mainly indicated for transvaginal sonography, but sometimes we can include these categories for transabdominal as well as transrectal sonography. If there are multiple lesions, suppose maybe bilateral lesions are available there, then the management is driven by the lesion with highest O-RADS score. coming to this definitions or terms, we call it in the lexicon. So follicle is defined as any cystic lesion with less than or equal to 3 centimeters. And corpus luteum is defined as any thick-walled cystic lesion less than 3 centimeters size with crenulated margins. And there are other categories. We'll be learning about it subsequently. And few of them are like unilocular cyst with solid component and no solid component, multilocular cyst, and multilocular cyst with solid component. So to call it as a unilocular cyst, we need to have a single compartment, but it may also have an incomplete septum. If there is a complete septum, it falls into the category of multilocular cyst. Okay, and to call it as a solid component, the thickening of the inner wall or the solid nodular component should be more than that of 3 mm in height or thickness. If the thickness is less than that of 3 mm, it is not considered as a solid component. And completely solid or predominantly solid lesions, we need to have at least 80% of the lesion as solid component when assessed in 2 orthogonal dimensions. As we all, the maximum diameter is the size of the lesion in any of the orthogonal planes. And there are few other terminologies like external contour. This is the external contour means the outer margin of the lesion. There are only 2 categories in this, either smooth or irregular. If the outer margin is very regular, then it is considered as smooth. If it is irregular, non-uniform type, then it falls into the irregular. And we need to note that sometimes we encounter lesions with lobulated outer margins. So those also fall under the irregular category. Even though the lobulated margins are smooth, but they all fall under the irregular category. And depending on the internal contents, if they show acoustic shadowing, such as in lesions with dermoid cyst, the acoustic shadowing should also be used. And other terminologies are like papillary projection or nodule. For a papillary projection, the thickness should be greater than or equal to 3 mm. And it should be arising from the cyst wall or septation, and it should be protruding into the cyst cavity. And we need to mention the number of papillary projections present in that lesion as well. And this is the smooth is used for the inner margin. For contour, like we use the outer margin. For inner margin also, we need to evaluate for assessing the lesion. And based on the contents, if the cyst is completely anechoic or some contents are present, we need to mention in the report. And vascularity is also used by O-RAD system. And there are 4 color scores. We call it as color scores on O-RAD. When there is no flow, it falls under 1. When there is minimal flow, it is 2. When there is moderate flow, it is 3. And very strong flow is considered as 4. And these will be the settings on the ultrasound machines which are recommended by the guidelines. So the velocity scale should be from 3 to 6 centimeters per second. And we need to adjust the Doppler gain to reduce the artifact levels. And these are scores for color scores for assessing the vascularity in the lesion. And there are other general and extra-ovarian findings as well. Like if the fluid is just limited to the pouch of Douglas, then we called it as cul-de-sac fluid, and we don't label it as ascites. When there is a nodularity or diffuse thickening of the peritoneal lining, then we call it as peritoneal thickening or nodularity. We can see the examples here. Here we see the free fluid present only limited to the pouch of Douglas posterior to the uterus. And here we see that the fluid is extending beyond the level of the fundus of uterus. We are not seeing the uterus as such, but we can see that the ascites is noted in the peritoneal cavity. Here we can see that there is omental nodular thickening. So, like we'll be discussing each category now. Coming to the first category, O-RADS 0, which means incomplete evaluation. So we need to call the patient back and for repeat study or alternate study. Or if the patient is not able to undergo ultrasound, then we need to have further investigation like MR maybe or CT. This could be due to some technical factors like bowel gas or large size of the lesion or location of the adnexal, like far from the field of view, or if the patient is unable to tolerate endovaginal imaging. Coming to the first category, O-RADS 1, it is the physiological category. It is relevant only in the premenopausal patients. And this lexicon suggests that any cystic lesion less than 3 centimeters, we label it them as follicle rather than calling it as a cyst. And we need to differentiate corpus luteum from follicle, and both follicle and corpus luteum less than 3 centimeters fall in this category. And these are the examples given in the journal. So this is a dominant follicle seen in one of the ovaries, anechoic lesion, and the size of the lesion is less than 3 centimeters. And this is a typical case of corpus luteal cyst with granulated margins with central anechoic cystic component. And corpus luteal cyst, as we all know, that sometimes it may not have the cystic central component. Even for those lesions, if there is peripheral vascularity and in the setting of pregnancy, we can label it them as corpus luteal cyst, and they all fall under the category of 1 according to this lexicon. And these are the examples from our practice. This is a case of dominant follicle in the left ovary, and the size of the follicle was less than 3 centimeters. This is another follicle, anechoic follicle, which was noted. And the typical corpus luteal cyst has a peripheral vascularity like ring of fire appearance with central cystic component, or may not be present. Okay, this was the corpus luteal cyst, thick-walled cyst with central cystic component in a pregnant lady. Coming to the O-RADS 2 category, these are almost certainly benign category with very less than 1% risk of malignancy. In this category, simple cysts, non-simple unilocular cysts with smooth wall, and classic benign lesions are all falling in this category, and the sizes of the lesion is less than 10 centimeters in maximal diameter. So for category 1, the maximum size was 3 centimeters. For category 2, less than 10 centimeters. And the classic benign lesions we'll be discussing in this category 2. Some of them are like typical hemorrhagic cyst. As we all know, it has a typical fishnet or reticular pattern with thin intersecting lines representing fibrin strands, or the hemorrhagic cyst may be in a stage of retracting clot stage, which shows an avascular echogenic component with angular straight or concave margins. This concave margins is specific for typical hemorrhagic cyst. The next typical benign lesion is dermoid cyst. It has a hyperechoic component with acoustic shadowing, and hyperechoic lines and dots are visualized in these lesions. And sometimes we see floating echogenic spherical structures. Typical endometrioma is less than 10 centimeters. And the endometrioma usually have, as we all know, ground glass or homogeneous level internal echoes. And the other benign lesions are like para-ovarian cyst or peritoneal inclusion cyst, and also typical hydrosalpinx. We'll be discussing about each of them. The para-ovarian cyst is a simple cyst seen separate from the ovary, and it moves independent of the ovary when pressure is applied by the transducer. The peritoneal inclusion cyst usually seen in postoperative patients, and it follows the contour of the adjacent pelvic organs or peritoneum. And the typical hydrosalpinx, it has incomplete septations with tubular configuration, and we see the typical endosalpingeal folds. We'll be showing. I'll be showing the examples of each of these benign lesions. This is a simple cyst, and the size is more than the 3 centimeters, but less than that of 10 centimeters. So for categorizing it as simple cyst in premenopausal women, the size should be falling from 3 to 10 centimeters. In postmenopausal women, any lesion with less than 10 centimeter size. So this was a case of simple cyst with size of 4.4 centimeters, and we do not see any septa or solid components in this lesion. And the other type of the lesions falling in this category are non-simple unilocular cyst with smooth margins. So we can see that there is an incomplete septa. Only when we see that there is complete septa, we call it as multilocular. So this is an incomplete septa seen in one of the cysts and then this is the example for it. And the size of the lesion should be less than 10 centimeters. And no internal echoes are seen in these lesions. But sometimes internal echoes can be seen. Okay, this is an example from the practice. This is a simple cyst with some small incomplete septa, unilocular cyst to be precise, and this is another unilocular cyst with internal echoes. And the classic benign lesions examples, I'll be showing it in the next slides. So this is a case of a typical hemorrhagic cyst with a typical fishnet pattern or reticular pattern, and this is a case of hemorrhagic cyst with in the retracted clot stage, and we see that the margins are concave in this clot, and no vascularity seen in the echogenic component of the lesion. And these are the other examples of hemorrhagic cyst and with a fishnet pattern and retracted clot stage. And this is a case of a dermoid cyst. As we all know, there is a hyperechoic component with the posterior shadowing, and sometimes we see the pathognomic floating echogenic spherical structures in the cystic lesion. So this is a typical case of dermoid cyst with hyperechoic component and posterior shadowing. Floating dots like structures are also seen in the dermoid cyst, and this is the floating ball sign. Sometimes we see the fluid level as well seen in this lesion. This is another case of dermoid cyst with floating dots and echogenic component with posterior shadowing. This is a case from the practice, echogenic component with posterior shadowing, and we see the fluid component as well. And in this lesion, we can see a echogenic calcification or maybe teeth-like structure in the dermoid cyst. This is another case with echogenic component with posterior shadowing, and these are the floating dots and fluid levels, and this is echogenic component with the posterior shadowing. And typical endometrioma, as we all know, has a ground glass homogeneous low level echoes seen in the cyst occupying almost the entire cyst with no vascularity. And this is the case of endometrioma shown in the article. These are the cases from practice, thick walled cystic lesion with dense internal echoes, homogeneous dense internal echoes with no vascularity, suggestive of endometrioma. And these are the example of simple para-ovarian cyst. We can see that the ovary is lying separate from the cystic lesion in the adnexa. Sometimes it could be compressing or abutting the ovary as well. And this is a case of typical peritoneal inclusion cyst. We see multiple septations within and following the contour of the pelvis. And this is a case of typical hydrosalpinx. We can see that endosalpingeal folds are seen in the lesion, and it has a typical S-shaped or tubular configuration. And the septations can be seen in hydrosalpinx, but they are incomplete. It is not reaching up to the other wall of the lesion. Here we see typical endosalpingeal folds, suggesting that it is hydrosalpinx. Coming to the O-RADS 3 category, these are all same benign lesions which were mentioned in category 2, but the size of the lesions is greater than that of 10 centimeters. And in this category, the other lesions are like multilocular cyst with less than 10 centimeter size and no solid component. And in the prior categories, color score was not included in the evaluation of the lesions. From category 3, color score is included in the evaluation of the lesion. So any multilocular cyst with color score of 1 to 3 falls in this category. Any solid appearing lesion with color score of 1 falls in this category. And unilocular cyst with any size and with wall irregularity falls in this category. So this is a case of unilocular cyst, and the size should be greater than or equal to 10 centimeters. And all those typical benign lesions which we discussed now fall under this category, provided they have a size of more than 10 centimeters. So this is a case of unilocular cyst with irregular inner wall. The thickness of the irregularity should be less than 3 millimeters. And vascularity is considered in this category. So any multilocular cyst with a higher score, like from 1 to 3, can be included in this category. That is from no to moderate flow. Solid or solid appearing lesions with low vascularity, that is low or minimal vascularity, falls under this category. So this is a solid lesion with no vascularity, and this is a multilocular cyst with some component of vascularity seen in this lesion. And this is a case from the practice showing that there is a complete septa, suggesting the multilocular cyst with no vascularity, we can say. So multilocular cyst with a score of 1 to 3 and falls under this category. This is a solid lesion in the adnexa. No vascularity was noted in this lesion. So any solid lesion with no vascularity falls under the category of O-RADS 3. So coming to O-RADS 4, it is intermediate risk category. The risk of malignancy is from 10 to 50%. In this category, we see multilocular cyst with no solid component. There are few restrictions for this. If the size is greater than 10 centimeters and having smooth inner wall and color score 1 to 3, multilocular cyst with these components fall under this category. Suppose the color score is high and any size lesion falls under multilocular cyst. Any unilocular cyst with a solid component and few projections, but few papillary projections less than 3, and any color score falls under this category. Multilocular cyst with solid component with color score of 1 to 2 falls under this category. Any solid lesion with intermediate vascularity from 2 to 3 falls under this category. So we can see that multilocular cyst here with size greater than 10 centimeters and color score of 1 to 3. If multilocular cyst with smooth inner wall and color score of 4 also falls under this category. Multilocular cyst with irregular inner margins and irregular septation and any score falls under this category. Multilocular cyst with solid or solid appearing component with color score of 1 to 2 falls under this component. If there is solid component, even if there is less vascularity, it is categorized as O-RADS 4. So this was a multilocular cyst with some solid component and complete septa and no vascularity. As there was solid component, it falls under the category of O-RADS 4. So coming to the unilocular cyst with solid, or if there is solid component in a unilocular cyst, it falls under the category of 4. Even if there are papillary projections, but less than 3, less than 4, then it falls under the category of O-RADS 4. So this is a case of unilocular cyst with a solid component, and the thickness of the lesion is definitely more than 3 mm. So with no vascularity, in view of solid component, it falls under the category of O-RADS 4, which signifies intermediate risk of malignancy. And this is another case of another unilocular cyst with solid component and no vascularity. So this is a solid component. In the previous category, the solid lesion with color score of 1 was considered as O-RADS 3 lesion. Here, solid component with 2 to 3 color score considered as O-RADS 4 lesion. Here we can see the examples for that. We can see that there is mild vascularity. So color score of 2 can be given for this. And there was a flow on waveform as well. Coming to the high risk category, O-RADS 5. So the typical descriptors that are highly predictive of malignancy are unilocular lesion, unilocular cyst with greater than 4 papillary projections, multilocular cyst with solid component with color scores of 3 to 4, and any solid lesion with color score of 4 of any size. And if there is ascites or associated peritoneal thickening, all those lesions also fall under the category of O-RADS 5. So these unilocular cyst with multiple projections greater than 4, multilocular cyst with solid component and color score of 3 to 4. So this was a case of multilocular cyst with solid component and mild vascularity, maybe color score of 2 can be given in this case. Solid unilocular cyst with solid component and vascularity was noted. Color score of 3 can be given in this lesion. All these lesions fall under the category of O-RADS 5. And this is a typical case of malignancy with solid component and vascularity. So any solid lesion with higher vascular score, color score, falls under the category of 5. So this is a complete solid lesion with high vascularity. Color score of 4 can be given in this lesion. If there is associated peritoneal nodule or ascites, it eventually falls under the category of 5. And we need to note that if there is a O-RADS 2 lesion and other causes of ascites like liver or kidney pathologies, we need to be careful with those kind of cases as well. This is a case of ascites, and we see bilateral solid lesions. This was a case of Krukenberg's tumor, and solid lesion with high vascularity. This falls under the category of O-RADS 5. Coming to the management, so we need to help the healthcare provider in deciding which lesions require no follow-up or conservative follow-up, and we need to consult with gynecologist or oncologist depending on the staging. So for 1 and 2 categories, for 1 we should not do any follow-ups. For category 2, if the size of the lesion for a simple cyst is between 5 to 10 centimeters, we advise follow-up in 8 to 12 weeks in premenopausal ladies and follow-up in 1 year for postmenopausal ladies. Okay. For a typical hemorrhagic cyst, most of the management is done by the gynecologist. If needed, the patients undergo MRI investigation for confirmation, or sometimes for a second opinion, ultrasound specialist can be utilized for confirmation of the diagnosis. And for category 3 lesions are managed by gynecologist. So these are the low risk malignancy O-RADS 3 lesions. These are also under the management of gynecologist. So we don't approach the gynecologist for category 3 lesions. Some category 4 lesions, gynecologist can be consulted for those intermediate risk cases. Depending on, it can be managed by gynecologist with gynecologist consultation or solely by gynecologist. For category 5, we need to directly refer them to gynecologist. Oh, thank you. And I thank Dr. Krishnamohan sir for giving me this opportunity. And for the images, Dr. Pratyaksha Rana should be thanked. She has provided me a lot of images. Thank you.
That was very insightful, sir. Nice presentation.
Now we can have the discussion, I guess.
Yeah. Ma'am, shall we proceed with the discussion?
Yes.
So, do you have any questions, ma'am?
As sir told, in O-RADS 4 is actually who should manage, that means gynecologist or oncologist. But after, if any findings, that means high risk findings, intermediate risk findings are there, we will do the tumor markers, CA125, CEA, and CA19-9 in perimenopausal woman to rule out whether it is malignant or benign. If the values are within normal limit, we will proceed. That means gynecologist, we will do normal PAH with lateral salpingo-oophorectomy. If tumor markers are on the higher range, then we will refer them to oncologist for extended surgery. That means they will take the paracolic omentectomy, and they will take the cytology for fluid for cytological examination, and peritoneum from the bladder and wherever the suspected area is there for further management.
Ma'am, what is the cutoff we take for CA125 levels?
So if it is more than 200, because if it is less than 35, it is normal only. If it is more than 35 or less than 200, we will consider it as endometrioma. If it is more than 200 and according to the MRI or ultrasound findings, it may vary. Because there are 1% chance of even endometriomas to be an cancerous condition. So depending upon the value, we will plan the management. We should do the staging laparotomy, or we should only do the hysterectomy with salpingo-oophorectomy.
Okay.
Sir, I have a question.
Yes, ma'am.
If consider any benign lesions like dermoid, they have the features of benign features. I mean, suppose for dermoid, we have all the ultrasound. Yeah, but the size exceeds 10 centimeters. Then into which category we put it?
As like immature teratomas usually have this category 5 projections or solid component with high vascularity, so it will fall under the category of 5, I guess. Like if you think, if even if you see papillary projections more than 4 and high vascularity, it directly goes to 5 irrespective of the size. Suppose we are thinking it is mature dermoid or teratoma with low vascularity and typical benign features, then depending on the size, if less than 10, category 2, if more than 10, category 3. That's how we do. If we think as malignant, and in our clinical practice, as ma'am will agree, like even if we like aggressively treat the lesion, it is better for the patient rather than like unnecessary delaying the treatment for a cancerous patient, I feel so.
Yeah. Yes.
Yeah, if we upstage the scoring, it will be better, I guess.
Yes.
And there was one more line that depending on the clinical situation, we need not strictly follow the O-RADS. So depending on our clinical acumen, we can definitely like upstage or downstage the scoring.
Yeah. Yeah. So thank you, sir. That was really helpful.
Thank you.
Thank you,
So
ma'am, for joining us.
Thank you.
Thank you.
we'll close.
Thank you.
Thank
Yeah,
you.
we'll close the session. Thank you.